Hi, this is Congressman Pallone. I'm glad that all the members are joining us today for this very informative forum on testing, contact tracing, and surveillance and what we should be doing to control the pandemic. I do want members to know that this is the first time that our forum is actually open to the press. So this is a public forum. The press is on the line, and they will have the feedback after as well. We have 3 guests today that I'd like to introduce, but let me just say this. Our committee, as all of you know, has played a major role in combating the coronavirus pandemic. The focus today is on testing, contact tracing, and surveillance, and we have already done a lot, since this is in our jurisdiction, to address this issue. So, for example, in the last bill that the president signed, we had $25 billion for testing. We set up, through our authorizing language, a national strategic plan with instructions to the administration and the states on what they had to do to build out the testing as well as the contact tracing. We intend to do more in the next piece of legislation, both in terms of more funding as well as addressing this and helping both the country and the states reopen, because obviously contact tracing, testing, and surveillance is very important to our effort to reopen the economy. So today's briefers are going to give us their perspective on these issues and activities and what steps the federal, state, and local governments should be considering to successfully contain and mitigate COVID and reopen the economy. We've already relied to some extent on their suggestions in the legislation we've already done. So I want to thank them for being here. They're certainly familiar to our committee. First is Andy Slavitt, who is the former acting administrator of the Centers for Medicare and Medicaid Services under President Obama and is the founder of United States of Care. Secondly is Mark McClellan, who was the former CMS administrator and former FDA commissioner under President Bush, and currently the director of the Duke Margolis Center for Health Policy. And both Dr. McClellan and Mr. Slavitt recently authored a letter along with 14 other bipartisan public health leaders detailing policies they say would be vital parts of safely reopening the economy. And last but not least is Avik Roy, the co-founder and president of the Foundation for Research on Equal Opportunity. I want to welcome all of you. Before I turn this over to our ranking member, I did want to say to everyone again, this is open to the public. This is live as we speak, I guess is the best way to put it. After our presenters and Greg's presentation, we will take questions from members alternating between Democrats and Republicans based on the seniority in the full committee. And I would ask everyone, please try to be brief. Limit your questions to a minute. I'm asking the speakers to be brief in their response because we have 55 members. I don't know that they're all on, but most of them probably are, and we'll never get through them unless we brief. We have 90 minutes total here. So with that, I'll turn it over to our ranking member, Greg Walden. And again, Greg, thank you for all your cooperation, both in the legislation as well as with these forums. Without you, it really wouldn't be a truly bipartisan effort. You make it so. So thank you, Greg.
Well, thank you, Mr. Chairman, and I too want to welcome our speakers today. These are all very distinguished gentlemen who have played big in the healthcare space for many years and been very involved in public policy and trying to do what we try to do, Frank, and that's leave this country better than we found it in this space. So I really am looking forward to their comments. And I do hope that we have an opportunity to work in a bipartisan way with any CARES future package the speaker's working on. We've really not been invited into those discussions yet from the minority standpoint, but I do hope so going forward, because I know in the past where we've worked together, we've developed some pretty good product. coming out of it. And this disease doesn't pick people based on their party registration. Clearly, there's additional work we need to do on a bipartisan base to look at reforming the Strategic National Stockpile. I think we all work together on the PAPA Act, Pandemic All Hazard Preparedness Act, to try and get it right. And I think this record-setting pandemic has taught us that there are things that we need to do even better going forward. We need to learn more about the SNS, and we've got some ideas on that. I also think we need to do more oversight when it comes to provider relief and input from those on the front lines to find out how what we've done is working and what's not. I know we're all in contact with our local healthcare providers, but I look forward when we can have a hearing on that sort of information, as well as picking up on how we found ourselves as a nation with a supply chain that left us short when it came to personal protective equipment. And then finally, the last two things I'd talk about is mental health. We're all seeing these horrible, tragic stories about suicides and the uptick in need for mental health services. And I think we've got to do some more work on looking at what's working, what's not, and what those gaps are in a formal committee setting. And then looking at the gaps in outcomes and access, especially in communities of color that are really being hard hit. And so I think all that work remains in front of us, Mr. Chairman, and I know we've had a good partnership working on these things in the past, and I trust we will going into the future. But this morning I look forward to the presentations from our distinguished presenters, and with that, I know we'll have an opportunity to have some questions, and again, I just want to thank you, Mr. Chairman, for working with us, and we'll continue to work with you on these efforts as well to benefit the American people. With that, I would yield back.
Thank you, Greg. Now we're going to go to questions. I'm going to ask Greg to go first, and then we'll go to the in seniority on the full committee to the next Democrat. But again, I just want everyone to be reminded that this is live and open to the public. The press is listening. Okay, Zach, why don't we ask, Greg, why don't you ask the first
Mr. Chairman, I think we should hear from our presenters first, and then we can get into Q&A if that's okay. Okay.
I'm sorry, I wasn't thinking. I knew I was going to miss the presenters. Okay, so let's go in the order that I made, and we'll start with Andy Slavitt. Go ahead, Andy.
Thank you, Chairman Pallone and Ranking Member Walden. Americans are going through an incredibly difficult time right now. It's a confusing time. People are frightened. They're frustrated. They're unsure what to do. But on the other hand, they've been pulling together in larger numbers and with greater response than I think we've ever seen in at least my lifetime. Regardless of whatever their politics are, they are relying on one another and indeed leadership from state and federal government like never before. I think the opportunity for the Congress to gain public trust by having the public's back is unprecedented. And Americans are looking for a bipartisan response. It is comforting to Americans to see the way you have all pulled together and treated this as the emergency situation it is. People want the same things. I believe that everybody in the country, political leaders or Americans, want to open the country safely. They want to have their lives back. But they also know there will be no real economy without Americans feeling safe first. The economy where thousands of people are dying every day from an infectious disease is not a robust economy. Americans know that they are both highly infectious and asymptomatic and do not want to endanger themselves, their families, or their community members. Current status is that we are still experiencing a record death toll. We are heading towards 100,000 American lives lost, and we are not appreciably slowing. In fact, we perhaps might be even growing at that rate. For that, we have gained only very modest immunity, perhaps higher in New York and New Jersey, but nationwide in the very low single-digit percentages. That immunity, of course, has come at a great cost to American lives. So where that points us towards is strategies of containment and science and prevention and support for our most at-risk communities. The first step has been to have Americans socially distance, socially isolate, and that has saved tens, if not thousands, of lives. Americans have been in great unison, and they're likely to be able to do that and willing to do that for some amount of time longer. But certainly, I think longer than most political leaders give them credit for. However, they will not be able to do that indefinitely and need a strategy for getting to the next place. There are hotspots around the country. The 10 largest hotspots are now in rural communities. 9 of our 10 largest cities in the country are still growing and seeing spread. The next step has the potential to keep Americans in unison if done well. It also has the potential to be more contentious. Americans want to know what to do, and we should try to give folks the aligned message of helping people get back to their lives in a safe way. So let me focus on a couple of the critical recommendations. Number one is to continue the course that we've begun and that was begun by the White House Task Force, and that is to open the country safely. Don't cave into the narrative that testing Americans and contact tracing is too hard. It doesn't get easier without those steps. All of this while we make the healthcare system more resilient, get Americans back, and direct scientific resources accordingly. Dr. Birx's plan, containment and reopening, testing, contact tracing, and social isolation are the key to containing any future outbreaks as small campfires instead of raging forest fires. Thank you for what you have done on testing so far. I believe with that money need to come a new set of focal points on testing. That means industrializing testing and turning it from a bespoke industry that does a cholesterol test over 3 or 4 days to a scaled industry that can do millions of tests a day. To do that, we will need to make significant changes, including barcoding, 24-hour turnaround, open sourcing our technology capabilities, and others that I've written about. Along with testing must come contact tracing. And contact tracing, I think, should not be a foreign or concerning topic to the public. Contact tracing at its simplest level essentially says, if Andy has been diagnosed positive with coronavirus on a Wednesday, let us help Andy figure out who all the people that I came into contact with between Monday and Wednesday and help warn them and make sure that they can take appropriate actions. This is not something that is Big Brother, should be driven by Big Brother, nor quite frankly could it be. This is something that our public health workforces, if adequately sized, funded, and resources know how to do. We then need to give Americans who are testing positive the option to socially isolate voluntarily in one of America's vacant hotel rooms. And if they are hourly workers and are not able to get their income paid for while they are in a 14-day isolation, we should offer them some sort of income replacement. We suggest that this be equivalent to a jury duty, because this really is a civil service that people are performing. Those recommendations, along with an engagement of the healthcare provider community to support this effort, which I believe Dr. McClellan will talk about, are indeed the result of bipartisan work from a number of scientific and healthcare leaders. We believe that these are initiatives that enjoy broad support and can enjoy broad support, hopefully, from the Congress and the administration. I will close with just making a couple of other points. I think allowing Americans to know that they can be tested as they need to, that they can, that their contacts can be traced, will allow Americans to feel safe again. It will allow Americans to get back into the economy, and it will allow Americans to start doing things that they won't possibly do otherwise. Without that feeling of safety, Americans will not be buying cars again, getting on airplanes. Businesses will not be signing leases. hiring lots of employees, and the economy will unfortunately continue to limp along, and we will have neither an improved death toll or an improved economy. Doing those things, I think, complements nicely some of the work Congress is already doing and considering, ensuring that the healthcare system is more resilient with flex capacity, addressing the needs of frontline healthcare workers, funding community health centers, Medicaid, family practices, and mental health resources, and then making sure that we have a public health overhaul of our long-term care facilities and are indeed taking care of the needs of high-risk populations. Supporting Americans, as you've started to do, will also include clear guidance and transparency on what the appropriate public health experts are suggesting that they do, continued support for small businesses and healthcare coverage for Americans, and then finally, directing the scientific and discovery resources to ensure that all the information necessary to get rapidly to a cure or rapidly to therapies or rapidly to vaccines or rapidly to a prophylaxis is made available to the appropriate parties, that there is appropriate funding for manufacturing backstop, and then, of course, equitable distribution of vaccines and therapies when they become available. So this is a lot for America to take on. It is a lot for Congress to take on. There's never been a greater time when Americans need the support of Congress and their state and local leaders than ever before. I'm grateful for all that you guys have done, men and women, and I appreciate you inviting me here today, and I'm happy to answer questions after you hear from my colleagues.
Thank you, Andy. And next we have Mark McClellan.
Great. Thank you, Mr. Chairman, Mr. Ranking Member, and I want to thank you for the opportunity to be with you today, but especially thank you for the really strong bipartisan leadership from this committee and the Congress on responding to the unprecedented health and economic consequences of this pandemic. The relief you provided already, more than $2 trillion for helping healthcare and Americans in all walks of life get through this, and the increasing amount of funding and attention to ways not only to help people who have lost their jobs and been so impacted, but get us out, help us move forward in this pandemic is really important, and I appreciate the opportunity to help support those efforts today. Just to pick up on a few of the points that Andy Slavitt talked about, we are moving beyond this initial surge, which has seen a flattening of the curve in just about all parts of the country as a result of the extreme steps we've taken in social distancing and the extreme economic consequences from that. But we're not through it by any means. We've not seen a real decline in cases, more like a plateau of around 25, 30,000 new cases per day, with some areas like New York going down, but other regions still going up, though at much lower levels. So it is time to think about how to reopen safely and effectively. And I know there's a lot of impatience since the curve seemed to be flattening out and continuing rather than going away. There has been a lot written, including by my colleagues and I, people like Scott Gottlieb and others, on advice on how to reopen safely and effectively. I'm not going to go over all those details here, but I did want to hit a couple of important points. One important point is healthcare capacity, and I think the good news is that while we still have some shortages of protective equipment and other items, it's pretty good in most places. We haven't seen hospital systems overwhelmed. At this point, ventilators, ICU beds, and the like are showing significant excess capacity. So that's one foundation for starting to reopen. But as we reopen, especially with such a significant low number of cases still present, it's important to think about how we keep that case reproduction rate, as it's called, from going up, keep that below 1, so that we can keep on declining, or at least a steady path without significant impact on the health of Americans. And more bipartisan work there, building on the work you've done so far, will be extremely important. I do think we're going to be helped in the months and ahead with better treatments. We've seen the first stages of medical progress with remdesivir, and an unprecedented pace of vaccine development, as well as an unprecedented number of treatments in clinical testing and headed for clinical testing that could have a significant impact on taking the edge off the severity of the pandemic in a matter of months. But we're definitely not there yet, and we definitely have hard work ahead on containment, as Andy Slavitt emphasized, with such a significant number of persistent cases. We had a report from our center at Duke Margolis in collaboration with national experts around some key steps in containing the pandemic at this point. And I do want to emphasize the importance of testing and tracing contacts. There's been a lot written about this. Our testing capacity is going up. I think it's going to go up more in the weeks ahead as new kinds of tests, so-called next generation sequencing, come online, as we get better at doing tests in the community using cups and other easier mechanisms of collecting samples, and hopefully connect these systems better to our public health surveillance. But we're definitely not there yet. In addition, steps to maintain our ability to identify outbreaks when they occur using digital means and the like for symptoms based on respiratory problems, so-called syndromic surveillance, is very important. And because so much of this pandemic is driven by transmission among people who are younger and healthy and seem asymptomatic, we need to increase our testing, our surveillance, our syndromic surveillance in high-risk settings, especially nursing homes. We've seen some very constructive steps in recent days that can be effective. I think this includes regular testing of workers and individuals in these high-risk settings, going beyond just testing people who are symptomatic to be able to contain these outbreaks and really hopefully take an edge off the number of serious cases and deaths that have emerged from these high-risk settings. So that's going to require further steps on testing and tracing, building on what we've done so far. I've had a chance to talk with many members of Congress and others about the role of antibody testing or serologic testing. That's for people who have been exposed to the virus and developed immunity. This can help, I think, in the weeks and months ahead in our response, but it's important to keep in mind that the science isn't fully there yet. The reliability of widespread serologic testing isn't there yet. And as Andy emphasized, the vast majority of Americans are still not immune, especially in communities that have not been very hard hit so far. So it's very important to keep the reproduction rate of the virus down in the community. Serologic testing can help with that, but it's not going to be enough. And then finally, I want to emphasize the point that Andy made about response capacity, a very important area for further action by Congress, building on this shift from just filling in the big economic holes that we have in our country right now to helping us recover faster, is getting more employment, more activity directed towards containing the pandemic. And a very important part of that is this response capacity, and Andy Slavitt's already mentioned that. I'd just like to wrap up by highlighting one area where I think there is an important unmet need and where some further congressional action would be helpful, and that is in not only helping our healthcare providers who have been so hard hit in this pandemic, both having to deal with the surge over the past month and then seeing devastating losses in their revenues as people have been cut off from much of the health care they were used to receiving, helping these providers not only recover financially, but become a stronger part of what's needed in our new health care in the era of COVID-19 and beyond. That means more support for things like provider engagement in identifying risks in the community, helping people who do test positive get appropriate treatment, hopefully at home, so they don't occupy additional capacity in our healthcare system, using electronic data more effectively, sharing it more effectively to work with public health systems. We're seeing this start to happen around the country as academic centers and primary care practices and provider groups working with nursing homes are taking more steps to augment what our public health infrastructure needs to develop. CMS has taken some recent steps last week in paying for tests and paying for sample collection by healthcare providers that will help in this response. We had another report from Duke Margolis issued last week, again by a set of national experts on Medicare and healthcare payment policies that identified some further steps that could help here, such as payments to providers that are able to assist them in developing testing and collaboration capacities with public health authorities. And I think if we can bring our healthcare providers back in a way that helps them become more oriented to supporting these public health containment steps, will go a long way to developing the kinds of testing and tracing and pandemic management capabilities that are needed to keep the rate of cases from going up and enable economic reopening to succeed. Finally, business is a big part of this effort too. We're going to see more testing and activity there. I just want to emphasize that all of these sectors need to pull together for this next phase. Thank you very much for the opportunity to join you.
Thank you, Mark. Thank you so much. And finally, but last but not least, is Avik Roy. Avik, are you there? Can you make your presentation?
I'm here. Thank you very much. Yes. Thank you, Mr. Chairman, and thank you, Mr. Walden, for the opportunity and all the hard work you're doing. For those who are maybe newer to the committee or members of the press who are listening who are not familiar with the Foundation for Research on Equal Opportunity, we're a relatively new think tank founded in 2016. Our mission is to expand economic opportunity to those who least have it using the tools of individual liberty, free enterprise, and technological innovation. Our conviction is that you can achieve progressive policy outcomes using some of those tools and thereby find ways to bring Republicans and Democrats together to solve important policy problems. And obviously, the COVID-19 pandemic is devastating on both counts. Both the public health aspects of COVID-19 disproportionately fall on economically vulnerable populations and vulnerable populations generally, but also the economic piece, right? The economic devastation, the 30 million jobs lost, in particular, the crash of hourly jobs, hourly wage earners has been really, really difficult. And at FreeOp, about a month and a half ago now, or a month ago, we put out a major paper titled "A New Strategy for Bringing People Back to Work During COVID-19," emphasis on the during, that was co-authored by Lanhee Chen of the Hoover Institution, Bob Kocher of Stanford University, who was a member of President Obama's National Economic Council, and Bob Wachter, who is the chair of the Department of Medicine at the University of California, San Francisco, one of our nation's leading medical schools and hospitals. And our basic approach to this problem is we've been very concerned. We were all independently concerned, and then we came together to put our thoughts together. That we've had this binary approach to the COVID-19 problem, where if you care about the economy, if you want to reopen the economy, that means harming public health, and if you only care about public health, then the economy has to be shut down. And our argument is first of all that the sequence that has been the conventional wisdom about, well, we can't reopen the economy unless we do A, B, C, D, E in terms of testing, treatment, and vaccine and immunity. That timeline is not going to be is going to be difficult to achieve in the short term, and that you have a lot of businesses, particularly small businesses, that have only a handful of weeks, 2 to 4 weeks of cash on hand, that have not been able to participate in the Paycheck Protection Program, that are going to go out of business, potentially for good, if they can't get back online now, effectively, within weeks. So that's a big concern, that time is of the essence. And if we're waiting for a year to develop effective treatments, if we're waiting for a month to get testing scaled up, that's going to be too late for a lot of the businesses that are already suffering, particularly those smaller businesses. Big businesses, they have the balance sheets to survive. Smaller businesses don't. And so with that as a framework, basically saying if it takes us 5 years or 10 years or 18 years to develop a vaccine, remember, we've never developed a vaccine for HIV or hepatitis C. There's no guarantee we can develop a vaccine for SARS-CoV-2. Testing can scale up, and I'll get into that a little bit more in my remarks. Testing can scale up, but it will take a while. An effective treatment, people talked about remdesivir, right? But remdesivir has a relatively modest clinical effect. It's an important clinical effect, but it's not a cure. And so we can't wait until we've met those benchmarks to then think about reopening the economy. We have to think about what are the careful things we can do to reopen the economy now, even in the teeth of this pandemic. And the good news is there are certain things we can do. And they relate to the fact that we're starting to get more evidence about how COVID-19, the disease, and SARS-CoV-2, the virus, are different from the flu. So much of our policy response, particularly early on, was based on off-the-shelf playbooks that we inherited from influenza pandemics. But influenza is not the flu. Influenza is not COVID-19. And as a result, we now have the ability to have a more tailored response that is targeted to the populations that are most at risk with the COVID-19 pandemic. And in particular, we know that there is a significant skew in COVID-19 morbidity and mortality towards the elderly and those with cardiovascular chronic disease. And that means that we do have an opportunity carefully, and we detail exactly how carefully one can do this. We have an opportunity to carefully reopen schools for people who do not live with at-risk individuals. And we have the opportunity to reopen workplaces to people who are not at risk, relatively younger workers who aren't living with at-risk individuals, whether they are elderly or non-elderly with some of these chronic diseases. And again, we detail a lot of this in the paper. Another emerging concern that has come up that is really important to address is nursing homes. It turns out that among the states that actually report deaths by residents, nursing homes represent 40% of the deaths from COVID-19 in the United States, a remarkable share. And by the way, that's not unique to the U.S. There's a paper that's surveyed international data on this, and it's roughly the same. 40 to 50% of the deaths in countries that are reporting this are seeing that the share of the deaths are coming from nursing homes. So it's not merely that it's elderly individuals who are at high risk. It's specifically elderly individuals who live in nursing homes. And tragically, our early policy response has helped amplify the risk in nursing homes. So, for example, New York State and New Jersey issued orders that required nursing homes to accept back into their residences into COVID-19 patients who still had active infections who were being discharged from hospitals, because the fear, of course, 6 weeks ago was that we had to keep the ICU beds clear and we had to keep the hospital beds clear, and we had to get out anyone who wasn't severe. Well, that ended up seeding a lot of nursing homes, not just in those states, but across the country. And again, at freeop.org, we have a map that we've just published that maps out on a state-by-state basis the share of COVID-19 deaths that come from nursing home. The highest state as a percentage is Minnesota, 83.9%. In certain parts of New England, it's also well above 70%. But overall, the national average is 40%. So these are very serious numbers. And it's a great tragedy, and at the same time, it's an opportunity, which is to say, the more we can marshal our efforts to test, trace, and isolate in the nursing home setting, make sure that staff are not going from nursing home to nursing home, but staying within a particular facility, and that those nursing homes are using best practices in terms of surface cleaning and other tools, we can do a lot, hopefully, to mitigate the spread of COVID-19 and the morbidity and mortality in the nursing home population, while also then thereby having a more optimistic assessment of risk for the broader population. So that's the general approach that we've taken in this plan. Again, I've sent the full paper to the committee staff and also a summary of the paper that was published in the weekend review section of the Wall Street Journal the weekend before last, dated April 25th. So let me use my remaining time to just talk specifically about the issue of testing. And I'm very concerned, as my colleagues are, that the public in general and a number of policymakers have not necessarily, of course, the leadership of this committee, which is knee-deep in this stuff, but that a lot of people have an oversimplistic assessment of what testing is. We sort of think of testing as, the way we test our blood type or the way we have a pregnancy test. Those are the kinds of tests that we should be able to generate for SARS-CoV-2. And we may get to that point eventually, but we are far from that point today, because the two main categories of tests that we have important limitations. Antibody tests generally don't detect an active infection because it takes about 3 to 4 weeks after you've been infected by SARS-CoV-2 to start generating detectable levels of antibodies. So you can test everyone with antibodies or with antibody testing, but you're still going to have people, just like you have asymptomatic transmitters of the disease, you're going to have people that test negative for the virus, but actually are infected. That's the big problem with the antibody test. The big problem with the other major category of testing, the PCR tests, which dedicate or measure viral loads, viral mRNA loads, is those are good for detecting active infections, but they're generally speaking very cumbersome. The dominant way to conduct PCR tests is with a nasal swab, a 6-inch nasal swab that's very uncomfortable and intrusive. And it also, generally speaking, is administered in a professional healthcare setting like a clinic or a hospital or a lab. So, for example, there's a group at Harvard University from the Sapper Center. You may have seen the report that they put out for reopening, and they say, well, we should wait until we've done 2 to 5. We can do 2 to 5 million per day PCR tests before we reopen the economy. And even if we had the capacity, to do 2 million PCR, 5 million PCR tests a day, I have serious doubts that 5 million Americans will want to get their nasal passages infiltrated by these uncomfortable swabs each day. Now, of course, there may be newer approaches or newer technologies that enable us to solve this conundrum where we can measure active infections with less intrusive measures and more accurately. And I'm glad that the FDA has tightened up its emergency use authorization criteria so that we can get a better handle on the accuracy of the tests that are being deployed across the United States, as opposed to purely counting the number of tests. We have to really care about the accuracy of those tests. But I'm very concerned that it's going to take us a long time to get to a point where we can widely measure active infections and also measure them in a way that's not cumbersome to the patient or to the healthcare system. And so I'm happy in the Q&A to go into that in more detail. But bottom line, we've got to be more creative and more targeted in how we think about reopening the economy, even as the pandemic endures. I think some governors are, and we're seeing some other countries use some creative ideas to do that. And again, I just want to emphasize this point about the nursing homes, both as a targeted area for more serious intervention, and in a counterintuitive way, perhaps as a source of optimism that if we can get the spread of COVID-19 in nursing homes under control, then the broader population is going to be in much better shape. Thank you very much, and I look forward to your questions.
Thank you, Avik, and let me thank all of our guest speakers today. We have about 45 minutes left for questions, and again, let's try to keep both the questions and the responses brief, because otherwise it's not fair and we never get to most of the people. And I would like to now start with our ranking member, Greg Walden.
Well, thanks a lot, Frank, and thanks to our panelists. Great presentations, and we look forward to reading your paper, Avik. I just got the link, so we'll get into that. So just a couple of real quick questions. We need to know what your recommended strategy for detecting asymptomatic cases is. That's one. The second is there's a lot being written, and I'm hearing a lot in my district about people who have not been allowed to get elective procedures done, or are concerned with contracting the COVID virus by going someplace where patients are going in for treatment, and so therefore they have not gone in, and they might be having a stroke or other serious illness. And I wonder if somebody's looking at that, because I think when you look at the mental health impacts of what we're going through as a result of the shutdown, when you look at the costs of flattening the curve, there are other impacts that are occurring in real time in our healthcare sector with layoffs where there are no cases, and then denying access for people who needed elective procedures. Some of that's starting to lift, but again, asymptomatic, how do we do that testing effectively? And then B is this whole piece of what are the health impacts of the process we're using today?
Sure. So on the first point on the asymptomatic testing, some of the approaches that people are trying out but haven't been fully validated yet include, instead of doing the nasal swab, using cheek saliva or a scraping of the tongue to generate a PCR sample. So there's active R&D going on there. Another potential area is antigens. where people are looking at viral antigens as opposed to antibodies to the virus that the patient generates, and that may be another way to detect an active infection without measuring RNA levels. Both of those, as I said today, we can't say for certain that we're going to have highly accurate tests that are validated by the FDA, but those are two other approaches. And so I do hope that over time, through some of these other approaches to measuring viral load that aren't PCR, or maybe PCR that have a more an easier way of sampling the patient, that we're going to get a better result. On the point about the care that's not being consumed, that's non-COVID related, this is a serious problem, and this is one of the reasons why it's a false choice to think about public health and the economy as it's one or the other. Because as we shut down the economy, for both reasons that you mentioned, Mr. Walden, both the fear that people have of going to a healthcare facility and getting infected, and also just the fact that so many services are not being offered right now. For both of those reasons, they both involve significant public health risks. Whether it's the person with an acute heart attack who's not getting care for that heart attack, or it's somebody who has a chronic disease, or whether it's high cholesterol diabetes, or somebody who has to wait 4 months to get diagnosed for cancer, and therefore the cancer is already spread throughout their body, right? So there are lots of challenges like that make it very important for us to restore people's confidence to the degree that it's possible in that basic kind of particularly outpatient but also inpatient healthcare. And so I think those things are related to the broader economic reopening, because if we are carefully and prudently able to reopen the economy and get people comfortable with going to the grocery store or going to any other sort of retail establishment, again, safely and prudently, then that comfort around going to their doctor's office is also going to increase.
All right. Did you want to move on, Greg?
Well, were there other members of the panel that wanted to comment?
I'll do very briefly. Just this is Andy Slavitt. These are great questions. I'll focus on the elective procedure piece. I think Avik's answer I agree with on the asymptomatic side. We need to, I think with asymptomatic populations, it's okay for lower reliability, quicker tests because they will give us quicker indicators and, of course, continuing to sample test populations. On the elective procedure side, I do think there's room to get back into offering elective procedures again. And remembering, an elective procedure isn't an elective procedure. Sometimes it's something quite serious, like removing growth of a cancer, and those things shouldn't be put off. This tends to work better when communities have created COVID-specific hospitals and non-COVID-specific hospitals, because you can open up the gates and say elective procedures are happening again, but no one will show up if you ask them to walk into a hospital where they risk getting infected. So the things that we talked about earlier, I wish we could just say, let's just open up and do them. I wish we could just open up businesses and people will show up. It's just not that way. Just like with businesses, you have to give people enough safety. And to do that, in this particular case, the communities that have COVID-specific hospitals are able to open up much more quickly because they're able to respond safely. Of course, telemedicine is part of the answer. And I would just point out also that we have many communities that are able to figure out more efficient ways to do things than might have been done before. And that's not entirely a bad thing either.
And Mr. Chairman, I just want to, go ahead, yeah.
It's Mark McClellan. Just briefly wanted to add that there are some good examples now of approaches to contain outbreaks in nursing homes. For example, Kaiser Permanente, their medical group, is working with nursing homes to support this kind of active testing of asymptomatic individuals and partnering with reporting of cases and the like. It's exactly that kind of healthcare, public health partnership that I hope further legislation and state action can support. On the elective surgical procedures, remember that the procedure and other elective procedures, remember that many of the procedures that people are missing now are in individuals who have existing conditions like heart disease or cancer or risk of cancer. And if they're not feeling comfortable going to the grocery store, they're definitely not feeling comfortable getting into the treatments that they need. So as Andy and others have emphasized, we do need to take further steps to support testing and access to safe services in those settings especially. And again, there are good examples of that happening around the country.
Yeah, I just want to make one closing comment, Mr. Chairman. One, I've got members that are trying to figure out how to get in line to ask questions, so we need to restate how to do that. But second, on your point on COVID hospitals versus not, in these very rural areas like my district that would stretch from the Atlantic to Ohio, I've got counties with no cases. The hospitals are going broke, and they haven't been able to do anything. So I think there's a real disparity in some areas of the country, especially rural, remote, where literally they've yet to have a case, and the hospital can't even see a patient to do a colonoscopy or something. So we got to look at this regionally. Thank you.
I agree with you.
Yeah.
All right. So, Zach, why don't you explain again how members can ask a question? But I'll just warn everybody, we only have 40 minutes left, so we're not going to get to everyone. But we are going to go based on seniority. Maybe next week when we have our other hearings, we'll try to make up for it by going to the people that didn't get a chance today. So, Zach, go ahead.
Yes. As a reminder, if you haven't already, members can press *3 to enter the question queue in order to be recognized to ask a question. I will now recognize Representative Rush. Representative Rush, your line is live.
I want to thank you, Greg and Frank, for this hearing. I want to thank each and every one of our experts. I think that and I'm convinced that what we have to do is reimagine our public health system in order to reopen our economy. And that said, last week I introduced a bill which, if passed, would task the CDC with creating a national movement for testing and contact tracing. HR 666, the COVID-19 testing, reaching, and contacting everyone, or the TRACE Act, will create a grant program to allow grantees to pay individuals to conduct necessary door-to-door contact tracing and testing outreach in a safe environment. This is a bipartisan bill. Well, right now we've got over 57 co-sponsors. It calls for $100 billion for the implementation of the TRACE Act. The eligible entities include, but are not limited to, FQHCs, school-based health clinics, disproportionate share hospitals, academic medical centers, nonprofits, including faith-based organizations, high schools, and universities. And this will create a ubiquitous workforce that will go door to door. It will transition our unemployed American workers and will help stimulate economic activity that will result in reopening our economy. My question to Andy. Andy, is the $100 billion that my bill, the TRACE Act, calls for, is that in the ballpark of the funding needs that will make sure that the tracing and testing efforts in our nation would be ubiquitous, spread out all over the nation?
Thank you, Congressman. This is Andy, and thank you, of course, and all your co-sponsors for the TRACE Act. We believe that, as we understand it, it is broadly consistent with the bipartisan proposal that Mark and myself, Scott Gottlieb, Bill Frist, Mike Levitt, and many other scientific folks that worked with us have put together. We believe that the smart way to fund this is to do this in partnership with states so that they can get the money to hire the workforces, and that they should be hiring the workforce numbers are going to be based entirely on what their anticipated case count is. But we anticipate that this could be about 180,000 people in total need to be hired in the workforce. We believe that is a solid investment for the reasons you described. There are others that have estimated the number could be as low as 100,000, and others that have said it could be as high as 300,000. But we suggest that the states return back to the federal treasury any funds if their case counts turn out to be lower. I think United States of Care, which is the organization that I founded and am the chair of, has been working with a set of both federal and state recommendations, and has been and just today, this morning, has put forward a recommendation and a set of support for states to help them take advantage of best practices in hiring contact tracers and so forth. And we can make sure that the full committee gets all of the documents that United States of Care has put forward on that, as well as the original proposal that Mark and I and Scott and others have worked on.
Thank you, Andy. I'm going to move on. Zach, who's the next? Go to Republican.
Yes, I will now recognize Representative Shimkus. Representative Shimkus, your line is live.
Hey, great, thank you, and I'll try to be real brief. Greg made a good point, and the underreported story is rural America. Greg made the point that we're lucky to have a hospital versus having a COVID hospital or another hospital. I have 15,000 square miles, 33 counties, and 22 of them have no deaths. Of the 1,000 cases, over 600 are in just 2 counties. We've been pushing the governor for a regional approach. He just agreed, but it's just way too slow. And there is a coming public revolt if we don't allow an opening in these counties that don't have cases. In fact, there are some counties that are not complying with any rules anyway until there's a case. So the public health community needs to help us address rural America and the fact that there is little of this pandemic that is overwhelming these facilities, and our hospitals are going broke because they can't do elective procedures. And that's my statement, and I'll just listen to any response.
Well, I can jump in here, Mr. Shimkus. I mean, I share your concern about how we can't have a one-size-fits-all policy when the pandemic is affecting different regions of the country in different ways. Obviously, New York City and the tri-state area have a very different situation on their hands than a lot of rural counties do. That doesn't mean rural counties are safe, as we all know. We have had outbreaks in rural areas, but it does mean that the policy response can take into account the lower density in those locations, and that's something that we talk about extensively in our plan.
It's Mark McClellan on this, Representative. A number of states have taken steps in rural areas with low or no cases present. One example is the state of Texas, where I've had the opportunity to serve as an advisor to the governor along with other public health experts. And if there is a low or no caseload, I think there are opportunities to reopen regionally. It's important to have some testing capacity, some capacity to manage an outbreak if it occurs, since there are many older residents of those areas and facilities where we don't want to see more of outbreaks in nursing homes like we have before. But I think there are growing examples of how to do that right now.
And this is Andy Slavitt. I would just to echo, I think most governors now, both Democrat and Republican, including in states like Colorado and Minnesota, recognize what you're saying. North Carolina as well, and I think are headed that direction. I think there's 2 things to be cautious of course. One is that if there is a meat packing or meat processing plant or a nursing home, to pay extra attention there. And then secondly, that they make sure they have as good an early warning system as possible, because a rural community that has an outbreak that learns about it in the 2nd day will fare far, far better than one that learns about it in the 10th day.
All right, gentlemen. Can we, Zach, can you go to the next question?
I will now recognize Representative Eshoo. Representative Eshoo, your line is live.
Thank you, Frank, and thank you, Greg, and thank you to our guests for your excellent presentation. On nursing homes, I couldn't agree more. If we can bring down that number, representing 40% of all deaths, I think that the model of Governor Hogan in Maryland is something worth examining for all governors. But my question is, Andy and Mark, you're both former Medicaid directors. Can you instruct us on how we can use the Medicaid program to support the public health response in the pandemic? Specifically, what should Congress be doing to ensure that the states, have the support that they need to use Medicaid effectively during this crisis?
Andy, it's Mark. I'll start.
Go ahead, Mark.
You may want to add. I think, Congresswoman, there is a lot that Medicaid can do. Right now, as you heard from Representative Shimkus and others, many people, including many Medicaid beneficiaries, just aren't getting in for services. And so the more that Medicaid can support healthcare providers doing telemedicine, can support healthcare providers like at federally qualified health centers and DISH hospitals and the like, as Representative Rush talked about earlier, to get involved with reaching out to the populations that they know, the patients that they treat and who trust them, about how they can more effectively get access to testing, get access to care if they need it, is really important. And CMS has taken a number of steps to allow states to implement flexible approaches in Medicaid. As I noted earlier, our Duke Margolis Center had a report last week that described some further steps that payers like Medicaid could take instead of relying just on fee-for-service payments for visits into the hospital or the clinic, to build out more of a public health surveillance capability in conjunction with the local and state government initiatives to reach out to these underserved populations. They're already in the community, and there are a number of examples in areas across the country, Los Angeles, Boston, Austin, Texas, in some in your region too, in San Francisco, of these partnerships. And it seems to me to be a very appropriate use of Medicaid spending to move us in the direction of a more prevention-oriented and population health-focused healthcare system for the long term, but in the short term to really help contain these outbreaks and risks in vulnerable populations.
Yep, I just echo Mark that said, we need to empower Medicaid providers and communities and to reach out to and make available the kinds of services to Medicaid beneficiaries that will reduce their risks dramatically. So Medicaid providers are typically in many states getting paid much lower reimbursements for telemedicine than in Medicare or commercial. That puts Medicaid beneficiaries at a significant disadvantage because that means that providers are less willing to do calls with Medicaid providers, and that's with Medicaid beneficiaries, I should say, and that's important. I would also emphasize that there are a set of services, drug delivery, transportation, food and nutrition, et cetera, that Medicaid has always been tangential to for a long time, but we know that these social determinants they will create big risk factors, and if they're not handled, can lead people directly into the emergency rooms. So it is a good time for states to enhance flexibility, and of course for states that haven't expanded Medicaid but want to, at least for the period of this emergency, I think we ought to help make that possible because it will prevent a lot of downstream costs.
Thank you. Zach, you want to go to the next person? Next member?
I will now recognize Representative Burgess. Representative Burgess, your line is live.
Great. Thank you. And I did take myself off mute, so that's good. Mark, let me ask you a question that may not be fair, but I'm going to ask it anyway, and if you need to follow up with me afterwards, that's understandable and okay as well. But stated many times this morning that the testing is going to be one of the rate-limiting steps to getting the economy back open. We can't continue to pump federal dollars and print federal dollars to keep the economy afloat if we're not allowing the engine of the economy to begin to spin again. But it can't do that without adequate testing. Looking back to the early days of when this all started, and I really don't have a good explanation as to why the CDC was initially so slow to come out of the blocks with a testing regimen. But now we are where we are. Private sector involvement has really come on board in a big way, and that's a good thing. And the number of tests literally ramps up day by day. And again, if testing is the rate-limiting step for getting us back to working again, that's ultimately a good thing. My concern is a little over the horizon, the possibility of either a secondary wave or a bad flu season where our clinics and emergency rooms are crowded with influenza-like illnesses, and the need to differentiate and discern between those illnesses becomes critically important. Mark, in your position, you've uniquely been head of the FDA and head of CMS. So you've kind of had firsthand experience with, say, the Center for Devices and Radiological Health at the FDA that regulates medical devices, and some tests are regulated as medical devices. And through CMS, you've had experience with CLIA, which regulates the laboratory developed tests. So can you share with us any of the concerns that you have in facing what may be a couple of months ahead of us, but still an important break point or branch point with the testing?
Yeah, thanks, Dr. Burgess. I know how much we've both been working on issues in Texas and elsewhere to address this challenge. I do think we are making a lot of progress. It was a slow start. To this point, we're probably getting up closer to 2 million tests per week. It's not at the level that some have called for, 2 to 3 million per day anytime soon, but it is going to get better. The capacity should go up in the near term, both in terms of numbers of tests that can be performed as we bring online more efficient versions of doing lab tests, like with next generation sequencing. Illumina, Thermo Fisher, other companies are working and bringing products to the market at large scale in the weeks ahead in those areas. We're going to get better at doing tests that are easier to perform, that can be performed just under supervision by a provider, even over the internet, and that can be self-administered, like spit tests, instead of having to do the deep nasal swab. So Rutgers, as Chairman Pallone knows, has developed a test in this area. LabCorp is starting to distribute a home-based test. Those kind of steps will help. I think the challenge is going to be, as we don't have as many tests as we'd really like to have, can we work hard to get the tests to where they're most needed? And the CDC has recommended people who have symptoms that could be COVID-19, so you can detect early and not have people have to, wait and stay at home, and so they're, not going into their job at a nursing home or a healthcare facility or the like, where they might expose someone who's at risk. We can do testing to help get a better handle on people with symptoms, and we can also do testing in these high-risk settings. We talked about it in nursing homes and meatpacking plants and other areas for people who aren't symptomatic, to do surveillance about whether there is a chance of an outbreak. And I think those kinds of steps would enable us to go a lot further, get a lot of bang for the buck with the tests that are coming over the coming weeks. So we're not there yet. But I think we can get there in a matter of weeks to give people a lot more confidence that we can keep the current level of cases under control, if not get it back on a reproductive rate of the virus of less than 1 in the communities where we do have ongoing outbreaks. We just add that this is very important to do, as you said, before we get to the fall. In the fall, there's not only a higher risk of another wave for COVID-19 based on what we've seen in past pandemics and what we expect based on people getting to closer quarters and the cooler weather. But as you said, influenza outbreak is going to mean, which always comes seasonally, is going to mean the need for more testing and more differentiation to make sure that we're not going to see a recurrence in deaths. But I think those are all very doable steps in the coming weeks with the kind of support that we've talked about in this hearing.
Thank you. Thanks, Mike. Zach, who's our next person, next member?
Yes, and just as a reminder to everyone, to enter the question queue, you can press *3. I will now recognize Representative Engel. Representative Engel, your line is live.
Thank you. I have a very simple question. What type of coronavirus surveillance system do we need to build, or is it possible to leverage existing systems?
Well, people are leveraging existing systems in the sense of vaccine technologies that were developed against the original SARS coronavirus in 2003 and also the Middle East respiratory virus MERS. So some of those technologies, for example, Moderna is a company that is deploying. One of the reasons they went rapidly into clinical development is they took an old SARS MERS chassis, you could say, for their mRNA technology into development for SARS-CoV-2. So people are trying that. But again, I feel like there has been a lot of acceptance of this argument that we're going to have a vaccine in the next 12 to 18 months. And look, I hope, like every American, everyone in the world, that's true. But if we go by the actual probabilities and the history of vaccine development, we have zero assurance that we'll meet that timeline. The Ebola virus, which is the fastest recent viral vaccine developed on record, that was for a novel virus that took 5 years. From start to finish. And again, HIV and hepatitis, we still don't have vaccines, despite enormous amount of investment and intelligence being brought to bear. So let's hope for the best, but we can't assume anything.
Representative Engel, is your question really focusing on vaccines or more on surveillance? I maybe have a little bit to add, if, depending on what you most want to hear about.
Sure. Please add. Yeah.
Okay, well, so sticking with vaccines, just to give it a little bit more optimistic tone, we are putting way more financial support and have way more technology at our disposal than we did in those previous epidemics. I was FDA commissioner for SARS, and there was an effort underway there to develop a vaccine. Fortunately, we contained and eliminated that epidemic before the whole development process got completed. With MERS, similar kinds of steps. So we do have a foundation to build on, but we've learned a lot from Ebola and some of the other areas where vaccines have been developed. And there are both some new vaccine technologies coming along. So Moderna is already in testing, as Avik mentioned. There is other vaccines building on existing platforms, such as those based on harmless viruses that carry enough of the proteins from the coronavirus to induce immunity, we hope. And there are multiple companies doing this. So there's going to be, in this summer, which has never happened before, at least several vaccines in more advanced clinical trials. And behind that, a number of additional vaccines, I'd say at least 5 or 6 that will be in clinical trials this fall. And those clinical trials, if we do it right, can go pretty quickly. It takes a few months. You need to test in a lot of people because you're giving these vaccines to people who are relatively who are healthy in many cases. So you want to make sure they're safe enough. You want to give them time to make sure people get a strong immune response. So you can't do it overnight. It takes several months to do that clinical testing. But what's also different here is that we're doing production scale up at exactly the same time. So, for example, Johnson & Johnson has already committed to building the capacity within the U.S. for several 100 million doses, building capacity elsewhere for millions more, at the same time as the testing is ongoing. We may need to throw all those vaccines away if it doesn't end up working in the clinical tests. But if we do things right, we will have a lot of shots on goal in the short to medium term and potentially have these available, especially for high-risk individuals like healthcare workers on the front line of an outbreak this fall. So that's not for sure, but it is unprecedented in terms of the scientific capabilities and in terms of the attention to clinical testing that's done right but efficiently, and clinical development production that's done at the same time not sequentially. Now, I'd also add that we do have some treatments that are helping. They're not great, as Avik said, but that's the way medical progress occurs. You get antivirals like we did with HIV and Hep C that make a bit of a difference. You add to that, there's a lot of testing going on, including for people who have very severe complications of COVID-19, antibody-based treatments that may also take the edge off. None of that is for sure, but I'd say that we're going to be in a better position in 3 or 4 months in terms of containing at least the most serious cases, taking some of the edge off the pandemic if we keep up these very strong, unprecedented efforts. And it has benefited from a lot of congressional support, and more would probably be helpful. This is a way out of the pandemic, and we should get there as quickly as possible.
All right. We only have 15 minutes left, and we've only had 6 questions so far. Let's try to get through a few more here, Zach. Go ahead.
I will now recognize Representative McKinley. Representative McKinley, your line is live.
Can you hear me now?
Yes,
Hello?
we can hear you.
All right.
Yes.
My question, if falls back along the line that we've had with in rural America, we in West Virginia have been fortunate. We have a low incident rate, but we're leading in testing. We're testing over 50% higher rate than the nation is, but we're having fewer cases, fortunately, because we follow the guidelines. My concern here is for us in West Virginia is that the federal government, particularly the Bureau of Prisons, is shifting sick patients into West Virginia, and our prison facilities at Hazleton and Gilmer, they're prohibited from training the correctional officers how to use the equipment. So I'm curious, Chairman, what can we do to prevent this transfer of patients, sick inmates into it? Now, they say they've been tested, but in Gilmer County, they were all supposedly tested, and they were negative, and then as soon as they got there, 4 of them tested positive. So how do we do this? This is going to we're going to have a situation here in West Virginia where we have a pretty clean population, but now we're going to get inundated with the possibility of importing this virus. What would you suggest we do?
Well, I think you're addressing it to me. I'll look into it. I mean, the problem that you have, because last Friday we had a forum with the Congressional Black Caucus that was specifically focused on prisons, and the problem is you can't leave all these people in the prisons if they're not dangerous, because the prison isn't just made for them. You got prisons with many people in a cell, and it just becomes a breeding ground for the virus. So I know that many governors, including mine in New Jersey, have basically released anybody who didn't pose a threat into the community. But I understand what you're saying. So let me look at it and get back to you rather than using the time for our speakers. I'll get back to you, I promise. Why don't we go to the next one, Zach?
I will now recognize Representative DeGette. Representative DeGette, your line is live.
Thank you so much, Zach, and thanks, Chairman Pallone, and to our wonderful witnesses. As the chair of the Oversight and Investigation Subcommittee, we've already been doing a lot of groundwork investigating these issues that have been raised today. Mr. Walden, I was really pleased to hear you talk about how we need to do oversight on the national stockpile, on issues like why we were short on PPE, mental health, communities of color. That's all on my list and Mr. Guthrie's list. We expect that we're going to be issuing a plan for continued oversight and also some hearings within the next couple of days. And both Mr. Guthrie and I feel like our first real hearing should probably be on this testing issue because, as all of our witnesses today said, that's what we're going to need to reopen our country. So I have we've talked a lot about the testing, how we can ramp up the testing, how we are ramping up the testing. I'm wondering if our witnesses could give us some insight. Once we do have the ability to do widespread testing, then we're going to need to do the contact tracing. Andy, I think you mentioned it. Maybe Mark, you did too. But I'm wondering if you can just talk briefly about what type of contact tracing you think would work, person-to-person contact tracing. There's been talk about cell phone tracing and so on. And what kind of a workforce would we need to do that? That's my question.
Maybe I'll begin, and Mark, you can follow. Thank you, Representative Teget. I think we believe that this is mostly going to be a public health workforce, that it is a workforce that is highly recruitable from the general population. It's a job that is not much different than a census taker job. Our estimate, based upon projected cases, is that there's something in the order of 180,000 people across the country that would need to be in these jobs. There's others that have estimated that as low as 100,000 credibly, and those that have estimated as high as 300,000 credibly, but that's going to depend upon the case count. We think that the process is sort of very tried and true. It's worked for smallpox, it's worked for measles, for HIV/AIDS. It's a little harder here given the spread rate, but we think those resources will get it done. Technology can play a role, but we don't think technology is a silver bullet. Technology can be a tool to, in effect, jog people's memory and remind them of where they've been and who they've been. And it can notify some people if they've been into contact with others, if they choose and if they opt in. But given privacy concerns, and we've polled on this, we think Americans to use the technology will want to have to opt in rather than be forced in. And we think that given that, that means that it's going to create a lot of holes. So while there is technology that can help, we think this is largely a process that's done by a workforce that can be trained and under the leadership of, say, an EIS officer. Mark, I don't know if you'd add that or change that anyway.
Yeah, just a couple of brief additional points. All those are great points. One is that there are more tools available now, so a lot of this has to be done by phone or direct, hopefully not direct contact very often, since many people can be reached by phone. Things that would help would be, number one, making sure the electronic data coming from the labs and point-of-care sites that are doing testing includes information that identifies the person. That's usually there for billing purposes anyway, but would really help get these tracking ability capacity done more efficiently. Second is relying on some of these digital tools that voluntarily can help target the right people for follow-up, and so that makes this more efficient. Maybe need less new people. And third is integration with the healthcare providers. There are lots of examples of this, like Partners in Health at Harvard Medical School, helping with the training and connecting people to the community health centers and other resources in the community so you can really reach higher risk settings. And I think there are a lot of healthcare providers who are underused right now and facing a lot of financial difficulty who could be an important partner in these public health efforts. Finally, it's important to do asymptomatic testing and thinking about concentrating your tracing resources in the highest risk outbreak settings, like the nursing homes and prisons and other facilities that we've talked about before. Having capacity to go in fast there behind the positive case is really important for containment. But all this can be part of a well-designed tracing program.
All right, thank you, Diana. Can we go to the next person, Zach?
I will now
Zach,
recognize
I think Pete Olson was in line.
Yes, I'm about to recognize Mr. Olson.
Okay, perfect.
Representative Olson, your line is live.
Well, thank you, Frank. Thank you, Greg. Thank you, Avik. Thank you, Andy, the special howdy to fellow Texas Mark. This telemedicine. That has popped up 2 times in the past 8 years back home. And we're a suburban district. I think of telemedicine, I think of ranches and farming. It happened first with a dialysis group called DaVita yesterday. And the day before it had a big provider group called Kelsey-Seybold. The Kelsey-Seybold people have a very important, I think, we should look at include in the next pass to address the COVID-19 crisis. Kelsey Siebold, Chairman, in 2005 invested a ton of money in a modern state-of-the-art telemedicine system. Sadly, the doctors would not buy into it. They got to see the patients. You can't do this on TV. So for 15 years, their ratio of actual visits to a clinic or use of telemedicine was about 83 to 17. I mean, just the doctors would not buy it. Within 10 days, March 25th through March 15th to 25th of this year, that flipped. They saw 83% come in through telemedicine, only 13% going to see the doctors at the clinics. That is great for beating this virus because no exposure to the providers, no exposure to the patients. It's cheaper. They can do it in rural communities. So I just encourage Chairman Pallone and Leader Walden to help include this in the bill that passes. This happened. They told us this happened because the administration waived some of the telemedicine rules. Without those waivers, this would not have happened. So hopefully we can pass something that at least extends those waivers or maybe authorize a pilot program because this is amazing what telemedicine's done here in Houston, Texas. And I know Andy commented about telemedicine. You want to make any comments, Andy, Mark, or Avik, about telemedicine helping out rural communities, suburbs, and cities?
Yeah, absolutely. I mean, first of all, that is one of the leading practices, not just in the district or in the state, but in the country. And I think I would endorse your view, Congressman Olson, that they bring a lot of wisdom to this. I think the focus on how to restructure care, particularly the primary care and early specialty setting, is a really important one. Many of these care providers are hurting for lack of business, but telemedicine is indeed part of the answer, and I think CMS believes, and I think many of us support this, that the changes made during this crisis towards telemedicine are good for patients, they're good for doctors, they're not just good for this crisis, they'll be good beyond that, and it's something that I think would make the healthcare system better. So I really support what you just said. And this is Andy, by the way.
I agree. This is Avik Roy. Yeah, I agree, Mr. Olson.
All right, I think we can take one more, Zach, and that's going to be it. Go ahead.
I will now recognize Representative Schakowsky. Representative Schakowsky, your line is live.
Oh, thank you so much. I'm really glad to be able to be with these great experts today. I wanted to thank the emphasis on nursing homes and testing, and I do hope that in the next bill we will also prioritize testing in nursing homes and good reporting of what's going on in the nursing homes as well. I wanted to ask Dr. Roy, I was actually kind of stunned when I heard you say schools could open if the students don't live with someone who is infected. When are you talking about that happening? And because people that are asymptomatic could carry the disease, and are you picturing the kids sitting close to each other and playing sports and eventually, of course, that's exactly what we want. But you mentioned that early on in your discussion of opening, so I wanted to ask you about that.
Thanks for the question, and good to hear from you. In the plan that we developed at the Foundation for Research on Equal Opportunity, which I've sent to the staff, we go into a lot of detail about exactly how you would carefully reopen schools, and I would add that one of my co-authors, Bob Kocher, is on Gavin Newsom, the governor of California's task force, where reopening schools is a major priority. In fact, they are actively considering trying to open the fall 2020 to 2021 school year a month early or several weeks early in order to make up for lost time in the spring, deploying some of the techniques and tools that we describe in this plan. So what are those? First of all, if we want to reopen schools, and the rationale, as I mentioned in my opening comments, is that school-age children are at very low risk for morbidity and mortality from the COVID-19 disease. So that's a reason to consider reopening schools, along with, of course, all the educational and economic reasons that opening schools matter, right? If you're a single mom and you need to go to work, but you can't go to work, let's say you're a pharmacist, so you want to work today, but you can't because you can't leave your kids at home alone, having the school open is a major issue. The fact that a lot of low-income communities depend on nutrition from the school lunch program, that's a major issue. So there are a lot of reasons besides education to get schools open if we can. Now, obviously, we want to still protect households where maybe the school-aged kid is living with their grandparents or living with a middle-aged individual who has a cardiovascular disease. We have to come up with ways to protect those individuals and also teachers who fall into those categories or staff that fall into those categories. So for the teachers and staff, the idea is that you would have paid leave so they wouldn't have to work in those schools. And for the households where a kid might be living with an at-risk family member or caregiver, that they would be able to stay home. And in the case of, say, for example, the California example, what California, I understand from Bob, is actively considering is having the state take on the role of creating a virtual learning lesson plan and curriculum that thereby that way the school districts at a district by district level aren't having to do this, but the state can take that leadership role and ensure that districts have virtual lesson plans for those kids who still have to stay home. And remember, this is for the protection of those children's family members and caregivers. So the idea here is how to maximize the opportunity. If the solution is everyone should stay home and not go to school, and your choice is between that and having some people be able to go to school and virtual alternatives for others, we choose choice B.
All right. We've reached our 90-minute mark, so I think we're going to have to stop. Let me just thank all of our speakers. I thought the questions were very good. I apologize to the members that we weren't able to get more questions in, and we'll try to make up for it with our forums or hearings next week by going to the people that didn't get a chance today. Greg, did you want to say anything, and then I'll just ask if our three presenters want to say anything before we close. Greg?
Well, thanks a lot, Frank, and appreciate the hearing, and certainly hearing from our panelists. This was most helpful as we all struggle to find the right path back to get America reopened and on our feet. So with that, I'll just turn it back to you, Frank, and say thanks and see you next week.
Thank you. Would each of you like to say something? I mean, you don't have to, but you're welcome to.
No, but thank you very much for considering our input. And I think I speak for my colleagues when I say we're all available to be resources to you during this challenging time. And good luck.
Yeah,
well,
absolutely.
Thank you.
I'll just say one thing, if I could, Mr. Chairman, which is I think I misunderstood Mr. Engel's question about mutations and their role. I thought he was asking about mutations and role in vaccine development. If he was asking about mutations in the virus and the role in surveillance, I just want to answer that really briefly, which is to say that it depends on the testing technology and modality. Certain tests I think are going to be just fine in a surveillance modality because they're not dependent on those mutations, particularly the spike protein of the coronavirus surface. But other technologies that depend more on, say, viral antigens, that's where mutations may play a role in the ultimate accuracy of those tests with different strains of SARS-CoV-2. So it's going to be a technology by technology question. And with that, I'll just say thank you to the committee for having us.
No, thanks to all of you. And of course, you gave us some documents before we got on the call. I'm not sure if those were all given out to the members, but if they weren't, we'll make sure that they are. Keep in touch with us as we go forward, because I know that your information is valuable as we do the next bill or the bills beyond. And also, let me thank, this was the first forum that we had that was open to the press, so it'll be interesting to see how that works out, but I want to thank those members of the media who joined us, and we'll see you all. We have a couple more forums or hearings next week. Thank you again.